Say you take your child and you make that step, you have this conversation with them, you take them to a provider. What should they expect as probably their next step in getting better?
Sure. So I'm a family physician, and so I see patients from newborns to geriatrics. And so I do see everybody kind of front line, and so you don't really know what the diagnosis is when someone comes in. So a child may come in with their parent and they may say, something's not right. Usually it's, I'm not sure what's going on, but they're not doing well in school. And we'll begin the conversation of, talking to them about what's going on, and talk to them about signs and symptoms of depression. If I think that a child has depression, I'll talk to the parent and the child about that and talk to them about different treatment options. Usually what I do is try to coordinate care and collaborate with a therapist, and I'll recommend therapy for the child and maybe a further evaluation with a child psychiatrist, depending on the condition. The model that I think works best is that I see the child and the parent, and then they go and they see the therapist as well. And then the child and parent say it's okay for the therapist and me to communicate. And so the child goes in, they talk to the therapist calls me, and we talk to each other about maybe what I'm seeing in the office, and the therapist talks about not things that are confidential between the child and the therapist, but things that they're doing as far as their plan and helping the child to get better. So it's really a team effort of everybody helping the child to get to remission and to get to that and to get to healing.
What's the general prognosis of once it's treated?
Prognosis is very good. Once a patient or child is diagnosed with depression, they can do very well. The problem is only about half of people are getting adequate treatment. And it's that initial barrier. It's the recognition by the community, whether it's teachers or parents, and by physicians or providers. And once you get through that initial barrier of, hey, this sounds like depression, we should talk about this and we should treat it, the prognosis is very good. Most people do incredibly well with therapy. Some people do need therapy and medication. And once they do have the combined therapy of medication and therapy, then most people have remission and don't have another episode of it the rest of their lives.
What physiologically happens to you when you're depressed?
So when we are, from the time we're born, our brain is constantly growing and developing. The pathways that the brain has are continuing to connect with each other. Chemicals are being developed in connections between brain cells where they're talking to each other. And when we have depression, those connections may not have the right chemical balance, or they may not have developed the right chemical balance by that time. And in adults, we know that those chemical pathways in brain growth is more solid, but it can still continue to grow and change. But in children and adolescents, those pathways are much less developed. So we find that children benefit from therapy where they can learn. They do cognitive behavioral therapy with a child psychologist who is skilled at helping the child to develop new ways of thinking and to address that, along with medications. The reason we don't just say medications alone is because those pathways aren't completely developed for them. And there's definitely benefit to therapy, and there may be benefit to medication. So it depends on each individual case. What we want to do is try to have the depression go into what we call remission. so that the child can then go on to function and be active and have a social life and do well in school.
What would you say to a parent who might have, a fear of putting their child on a medication?
It's scary, and I would acknowledge that. And I do acknowledge that with parents when I talk to them about it, because we don't like, as a father too, I don't like to put my children on medicine unless I have to. And anytime I put someone on medication, it's always what's the risk and what's the benefit. The benefit has to outweigh the risk. The conversation that I have with parents is to talk to them about, how their child is doing, and if they are not in crisis at that point, meaning that their depression is something that we can manage with talk therapy or talking to a psychologist or a therapist or in the office, that's okay. We can take some time and see where things go. But if things start to develop and we don't see the child's mood turning around, if they're still irritable, if they're not doing well at school and not doing well socially, then we want to revisit that. And I'll set that expectation up front. And it's continuous communication between me and the parents or caregivers and the teachers. One thing that we didn't touch on was suicide with children. And that's something that happens more frequently in boys than it does in girls. The incidence for girls is about 4 per 100,000 in the 10 to 24-year-olds. In boys, it's about 14 per 100,000 in the 10 to 24-year-olds. That's something that we don't ever want to have happen. We don't ever want to lose a child to suicide. And when this is something that is treatable, it's preventable, and it's something that we can, as a community, come together and help that child to overcome.